Good evening, everybody. I'm sure you agree that these stories that the four ladies shared were very powerful. And I could see from the chat box that some of you have been moved to tears. I think it's so important, and each of them brought in a completely different perspective. Asha highlighted the vulnerable group, the marginalized. And of course, we had Ashwini talk about the phone calls. Well, there are many questions, so I don't want to talk too much. So let's start off. Asha, there's a question for you that says, what can we do to bring these stories to the forefront and use these as triggers to make much needed change? Asha, that's a tough one, but would you like to say something on that?
Yes, thank you all, and thank you for the question. It is a tough question because I think it has to be tackled at different levels, and it's going to take us joining forces with administrators, managers, policymakers, in addition to what we do within our own, let's say, practice or clinic or hospital or health center or a birth center. So I think those connections and communications are going to be really important because we're going to need systemic change. We're going to need more. So just really quickly on, kind of on a very broad level, we're going to need more budgetary allocation. Right now, India just has about 1.28% towards public health expenditure for GDP. Cost of care is really high for the poor. And it has to be addressed. We have to expand universal health coverage that the world over, WHO and many countries have been calling for this. We need to make changes at the service level. We need to invest more in community systems, community-based care for, of course, for all health issues, but we're talking about maternal and newborn. And even though I brought out the really difficult examples, there we had some great examples as well where the A&M was empowered and really active, or the ASHA worker, and they're just incredibly valuable support in their communities. And finally, we're going to need to change provider behavior by not just talking about informed consent. Those things are, of course, very essential, but I think in India we have an added dimension of a fundamental problem of class and caste discrimination that's severe.
Thank you, Asha. Nisha, there is a question for you. It says, how do girls keep their voice after marriage when they are surrounded by their in-laws in their marital homes? Because I know that this was one of the things that Indy found very difficult when she was running antenatal clinics, the power of the mother-in-law or mother in decisions. Do you like to answer?
Great question there. Great question. In fact, just a couple of hours ago, I did this. We're doing a campaign on how do you prevent early marriage, because if she's a girl before 18 and she's getting married, it's even more vulnerable. I think the solution really is so complex and complicated, because not just that the girl needs to have information, she should have the access and agency. So that's one part of the problem that we need to solve. The second part is, how can we use her as a resource to convince her family, but also use other systemic changes to convince the family. So one of the very powerful things that has happened in this pandemic is it's come from the field. For example, there was this girl who realized that she needs to talk about early marriage and what are the problems of early marriage. She, in a very social distance safe way, has actually run campaigns in her own community. She spoke to mothers of girls who are getting married. And it's come back to us saying that one of the sessions, one girl's mother got up and said, oh, my child is going to get married in another 2 days and I'm going to stop the marriage. See, I think that's the power of enabling somebody within the community, becomes an asset within the community, because she knows the language to change the community We go and they'll say, you don't know my circumstances. So enabling that girl to be able to raise her voice is one of the ways. I know that in maybe 10 cases, it may not work, but at least she's going to stand up for her children. It's an intergenerational issue. It is the girl who can advocate for herself, because otherwise her voice will not matter in any of the decisions. And marriage or children are one of those decisions she will take. So it has to be systemic. Dr. Evita, I think you're on mute.
Sorry. I said, thank you for that. And the work that you do, empowering these young girls, to find their voice and prepare them is also, I need to congratulate you on that. There is a question here, and I'm not sure who will like to address it, but it says, does the age of the woman make a difference to how they perceive they are treated during birth? Can I throw this at you, Suman? Before you answer, Suman, I just want to thank you for your story. You touched a spot there when you spoke about healing and not sharing that for 11 years, and you weren't even aware that you were holding it in. Thank you for sharing that. Yeah, go ahead.
Thank you. So your question about age, possibly. I think when I was in India pregnant with Luca, my age was quite a concern to my doctor. She'd bring it up every time. This was at the first hospital I was in. She would bring it up each time that I was an older mom. I was in my 40s, and therefore, that there was a lot more caution around it. I was in my 30s the first time round, and so I guess I didn't feel like they hadn't involved me in anything. I didn't at all feel like I wasn't included in any conversation because they might feel that I'm young, because obviously they had my records there. But I do know of some women who have felt that, there's almost this kind of feeling of possibly a judgment as well because they are younger. And then sometimes this thing, well, shall we just kind of go ahead and do what we think is best? I don't think in either of my pregnancies I actually felt that. There was just a lot more caution around the second time. I just found that quite funny. There were certain things that I was told I couldn't do and should do. But yeah, I think age can make a difference. I think that sometimes there are certain options that doctors may feel that actually is this person do we ask them? I know that I personally met people who have felt, well, I didn't really get asked and they were younger. They were much, 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 much younger. And then when they went on to have children, it was a very different experience when they were older. So I've heard stories. I don't know how widespread it is. I don't know what it's like globally, but I'm sure it exists.
Well, certainly, as an obstetrician and entering into midwifery, I began to look at age totally in a whole different light. And if anything irked me, it was the term elderly priming. It just used to get me, those words. And I became very conscious too of the language we use when we talk to women. Yeah. Let's go on to another question. Can care be free at the source with no monies exchanging to the woman, so she's not made vulnerable in an abusive relationship? Asha, would you like to tackle that?
It can. There has to be the political will. I mean, we in India, I'm talking about India, we have had really kind of successive generations of insurance programs for the poor since about 2006. And now, the latest being the Ayushman Bharat. So, that has been kind of an elusive goal. And so there's a lot of variation in the data. It's and India is such a huge country, but I think broadly it's safe to say that while now some populations may have access to free care initially, a lot of these insurance programs do not cover the indirect costs or follow-up care. So what's been interesting is when you look at expenditure data, out-of-pocket expenditure, you would expect to reduce when you have increasing insurance coverage. And we actually haven't seen that across the board to say that's a really robust correlation and finding. And, you know, we still are in that era of user fees. I mean, even now, if you go to any, you know, hospital where, you know, in India, that's a government hospital, and, you know, it's actually very hard to get free care. A lot of things, you know, we haven't really gotten rid of the whole user fee approach, although the World Bank, who ushered it in, said it doesn't work and it's really detrimental.
Mm-hmm. Thank you, Asha. It is a difficult one because there really is no free care, though we do talk about free care, but people do have enough problems there. Ashwini, there is a question, because you know what you did during the pandemic through Bangalore Birth Network, setting up that helpline. I mean, I was totally surprised that you should get a call from Pakistan and from out of India for help, but you know, amazing. One of our delegates wants to know, how did you find the technology, the resources? Because you trained people, I believe, in a very short while to handle these calls. Can you tell us more about setting this? I'm presuming this has to be a short answer, and I'm wondering how you're going to do that.
Of course. Thank you for the question, Dr. Evita. Anyway, it was, as I said during the recording, that it was tough time for us to reach to women, because we used to get numerous direct messaging to our websites, our Facebook pages, Instagram pages before starting this. We could sense that there is a need of guidance for people, for women around. So that we used our helpline number, a software where we get a missed call. Okay, that's how the soft technological part of it, where we have a missed call service system, and our counselors will call back to the number. And speaking about the thing, how we trained the counselors, that was really awesome, that we could get many volunteers, and we were recruiting these people. We were giving demo calls, and from that we got 18 super quality volunteers, and they've been trained by educators, health professionals with the guidelines of WHO, as I mentioned to the WHO, and they were like given guidelines on how to answer the questions, how to analyze the question, answer it, and if not if they don't know the answer of the question, if they don't able to find an answer for that, they have to get it to higher next step, or to ask someone who was senior to them. So we had a very planned process for this. So there is no wrong happening there. Every queries have been answered, and we are answering, and we are ready to get calls and to answer for questions and to help people, women around.
Thank you, Ashwini. Thank you. I'd just like to share the poll that ran before the session. The questions: do birth memories last a lifetime? And 96% said yes, but 2% said no, and 2% said we don't know. Have you ever witnessed a physiological birth? And 90% said yes, but 10% said no. And I think this is a huge problem, and some of us are wondering, if medical students should actually watch a physiological birth, because today we hardly see that or even understand what natural birth is all about, because we've become so interventional. What was the main reason? One of the questions was that women are not allowed to birth in positions of their choice. And 96% said it's lack of training. And 4% said it's not practical. How often do you support women who challenge your beliefs or push your boundaries? And 15% said, no, I wouldn't support, never. 35% said sometimes, but 50% said often. And the last question was, do you discuss a birth plan with the woman you are looking after during your antenatal care? 90% said yes, and 10% said no. So we still have a long way to go in terms of, care, in terms of listening, in terms of giving women knowledge, choices, freedom to make choices. Well, there is a question here that says, and that's a difficult one, can we teach empathy to the healthcare workers? Like basic life support is mandatory. Can empathy and compassion be made mandatory? I'm not sure who would like to answer that. Anybody?
We can teach empathy. And I think it starts with living empathy and practicing empathy with each other. So, and of course there are training modules, there are kind of, behavior change things available, but it really starts, I think, at an internal place and making it important and articulating the need for empathy in all of our professional interactions and meetings and trainings when we do rounds or we have our case meetings, whatever in a clinical setting. I think it's certainly possible. Whatever you pay attention to increases and grows. So if we pay attention to empathy, I think we'll see change.
Thank you, Asha, because I think that's a very, very difficult question to answer.
If I can add, Dr. Evita.
Yes, please.
My experience of working with teachers and public funded teachers on the same issue, it's about how do we teach teachers to be empathetic to children and create child-friendly environments. More often than not, it's not let's do a couple of programs, but it goes so deep into their own biases, how they have been discriminated, what made them want empathy, and comes from that space of this can happen to you, me, and how do we do it systemically. And most training programs look at it very like, I have this framework, I have this structure, it's a 3-module, 5-module, whatever, but they really don't get down into really going to the biases the people themselves are facing, because we are part of the same society. And I think just it is these levers are all connected, and it goes so much deeper, especially with teachers. It goes into really understanding where they have felt discrimination, and from that point is where the change happens. So I'm sure there are enough of those things happening even in the healthcare, but I think it has to come from that, like Asha said, a very deep place of really getting down to them as a person, because them as a person is important in the healthcare and the system. So not too many people address them as a person, sort of a unit.
Yes.
In such programs.
Yes. No, we learned that when we were involved in training in Telangana, and we had 30 nurses, and we realized to teach respectful care has to begin with us. The way we treat each other first, the way we treat the staff around us. And if we can't be respectful for each other, then how do we offer that to women? Simon, you touched a very important point about listening, about, because you said you found healing and you found people listening to you. One of the questions that I wish to ask, because both you and Anusha spoke about the midwife. Do you feel women in India are prepared to be under a midwife's care without feeling that they're not getting the best service because they're so used to having a doctor take care of them? Have you, Anusha, felt that at any point? Or did you feel, okay, I'm now with a midwife? Or did you feel comfortable because you were offered collaborative care? In fact, both of you were offered collaborative care. Do you think we still have a long way to go?
I think there is still a way to go. for me, I didn't question it. I think because I'd had that initial meeting as well, I'd come in and so much had happened for me at that point. I think so much of this is relational as well. You know, at that point when I met Indy and the team, I didn't know them. But, you know, there was this invitation into a conversation, you know, and I think there's something about that. There's something about being relational, you know, with those women, and just to kind of build that trust, because it's a mind shift that needs to, it's a mindset that needs to shift. You know, it's almost a culture, isn't it, in itself, that the doctors call the shots, and then now they've got these midwives in the mix, and they're not quite sure, you know, where do these midwives sit. I've come from obviously the UK, and midwifery here is honored in a very different way. You know, it has its place. So when I got there, to me, I was more than grateful to be under midwives. I didn't need a doctor necessarily, if at all. But I remember at the time, our maid, she was saying to me, "Well, are you not going to see a doctor? Is a doctor not going to deliver your baby?" And she was horrified. She was like, "Are you going to be okay?" You know, almost like it was a naivety, you know, that she just didn't understand the capability of a midwife. She just didn't realize that they had the authority even to be able to do that. So yeah, I think there is, I mean, it wasn't just her. You know, there are many women who still kind of feel like that, and it's confidence, isn't it? It's building that confidence. It's relational, and maybe there's a lot more workshops that need to be done. I think it's a whole culture in itself that needs to be cultivated. It's going to be, you know, it's going to be slow, but seeds are being sown, and you know, we've got to start from that point where we're sowing seeds of this and helping just shift that and grow that as a culture, really, a culture of honor. For starters, you know, with our previous question of empathy, and then also just just an awareness that midwives can deliver babies. It's okay. Yeah.
And it's so important, because the vision for India is, and the vision that we believe very strongly, is every pregnant woman should first see a midwife, and only if required sees a doctor. You know, you do that in the UK and many other countries around the world. Asha, when you work in rural communities, do you think women would accept midwives as the only care provider and feel comfortable? Because I'm absolutely convinced midwives have a different DNA, and the relationship that they build with women is so very different. What's your feeling? Because we are pushing for midwifery across India.
I do. I think there is going to be acceptance, because, you know, prior to the whole push for institutional deliveries, which started with the National Rural Health Mission in 2006, you know, rural areas predominantly had A&Ms. So, and they had traditional birth attendants, DIs. So, you know, that cultural, you know, memory is still there, I think. And I think people would welcome it. And especially when you have midwives who are integrated in the community, who are empowered, who are skilled, adequately skilled, I think that's a key part of it. It's going to be interesting to see how we integrate now this new cadre of midwives with the A&Ms and the ASHA workers. And I think that whole constellation in terms of, you know, how are we going to actually deliver, how are we going to develop these programs, and how are we going to deliver these programs is going to be a key question.
But bringing all of you back to where we started, listening to the voices of women. While we do continue with the midwifery program and the training, we need to raise this awareness among all levels of healthcare providers. And as an obstetrician, I think it's extremely important that we obstetricians learn to listen and learn to accept that women need to own their births. So from any of you, in fact, I would like each one of you to tell me how you think we could change this among our healthcare providers. Would Anusha like to offer one piece of advice that you?
I think especially in India, I think pregnancy and the woman's role to birth children is that whole attitude is there. So I think we should just accept that the woman who's pregnant, who's coming, is going to be anxious, and that's going to be the first port of call. To I think the whole interface has to be that, don't worry, we are there for you, because that anxiety is always there at the back of your mind. And especially like what Suman says, no matter what age is going to be a factor. If you have older women, I mean, even I was an older mother, and I kept hearing precious pregnancy thrown at me so many times in my first, that I really felt, wow, if this is not, then I'm not going to have a child, and what's going to happen. So yes, let's look at already recognizing that the woman is going to come with anxiety, and that is the starting point for the conversation, where I say, hey, first thing I need to do is emotionally bring her into this is a beautiful process. Because every time I heard you say it's natural, as a woman you will just know how to do it. That's the affirmation that I needed to listen. And then that's the journey that changed for me the second time, to say, I know it, all I need is somebody at my corner, and who's going to be with me in this. And Indy was just there, doing that role. So yes, the woman is going to be anxious, we need to listen to her, and there is somebody by her side who's not her partner, but somebody within the system who's there to listen to her. I think that has to change.
Thank you. And Asha, we believe that the poorest of the poor also needs to be heard. So you've brought some very powerful stories to the table this evening. And what would your advice be to the caregivers in that environment? How do we get them to listen?
Well, it's, I think it's it's multi-dimensional. There are many aspects and factors to it, but we have to benchmark it. It's not just a wish list or something we want. When we talk about how do we benchmark accountability, how do we benchmark performance, because we are, whether they're private centers or government centers, we are. And I think we need to figure out ways to, and it's being done in other places, how to benchmark compassionate care and empathy and listening. Yeah.
Thank you, Asha. Well, we certainly have to build up a very powerful network, and we need to get the women, because the WRA ran this amazing campaign of what do women want. And I think that has woken up many of us, just reading about that. Ashwini,
Yes.
you heard women so desperate. Yeah. Is there something you'd like to tell us?
Yeah, of course, Evita. The thing is, there was a common trend which I could see in each call, is that the fear. Even though the frequency of the calls has changed, the themes has changed, so like last 6-7 months, but the common factor which was remaining was fear. Either it be urban or rural, whatever it is, we could sense the fear. That fear has to be changed. Like that, the women who is coming to the health workers, they should have the confidence on us, on the professionals. That makes some sense, because whatever the question may be, whatever things, maybe antenatal checkup or vaccination, or about the admission in the a hospital, whatever it may be, but we could sense the fear of people when they come to us. That could be changed. That if you could change that, I think we win. Actually, we say that we are success, and people they come without any hesitation, any fear, and with full confidence. That can change actually the outlook.
So ultimately, we come down to, as someone said, it's the relationship, that whole relationship of trust that we need to build, and that the woman can feel comfortable to talk. But the important thing for all of us, as we listen to your stories, is to remember, when we meet a woman coming in with a pregnancy and she's been through birth before, it's so important to ask that simple question: how was your birth experience? And I think that is a good beginning to start building that trust, to send a message to that woman that you care enough to know her story and how she felt about it. Yeah. Well, we just have another 12 seconds, I think, to go. There are some questions. The Foxy Foundation in India, one of our delegates says, is probably the best advocate for this venture of listening to women's voices. For those of you from outside India, Foxy is really, it stands for the Federation of Obstetric Gynec Societies of India, and we have a 35,000 strong membership. And if we could, yes, become that platform for women's voices to be heard, it would be a very powerful channel. Well, I hope someone from Foxy is listening to this conversation. Well, with that, I'd like to, I think we're running out of time. And I'd like to thank each one of you for being with us here this evening, for your candor, for your compassion, for your interest, for your passion. And for those of you who represented the voices of the women you heard, and Anusha and Suman, for the courage to share your personal journeys with us. Thank you so much, and good night, at least for us here in India. Thank you.
Thank you.
Thank you.
Thank you so much.
you.